So our next, that nice transition to our next speaker, Mario Dang, who's head of the mechanical support and transplantation, cardiomyopathy and transplantation program at UCLA. And I'll just note, I think after this, we can take a very quick break, but we'll basically move directly to the case presentations.
Hi. Thank you very much for the invitation. It is an honor to be part of the Congenital Heart Disease Symposium, and I think reflects on our attempts to integrate and use the beautiful potential that UCLA has, and I'm proud to be part of this institution over the last 15 months. I want to briefly go through the updates of heart transplantation and congenital disease, basically stating that since the survival overall has doubled over the last 50 years, and that is owing to the improved surgical techniques. We do have new challenges with the adult congenital population, and the congenital disease as a cause of the heart transplantation in the pediatric population, 70% single ventricle physiology. About 2% of the adult transplants are due to congenital heart disease. So it's a fairly small fraction, but it's a very important fraction of the overall adult heart transplantation situation. As Dr. Lax alluded to the divide between single ventricle and non-single ventricle physiology, different indications were the most complex ones, clearly the single ventricle physiology. And the indications we cannot directly transfer from the adult criteria. It clearly includes, since there are no simple validated scores, such as in the adult onset heart failure population, like heart failure survival score in place, we do include quality of life functional parameters such as severe exercise tolerance and the overall, as I briefly alluded to yesterday in the discussion, the time course of progression, the gestalt of change over time as an indicator of progressive myocardial dysfunction and heart failure. And in addition to that, the arrhythmia situation also yesterday already discussed in some of the challenging Fontan patient cases that were presented at the same time with, for example, Fontan physiology, the question of not only on the too early side, but also on the too late side, when's the transition towards irreversible hepatic failure, which role does protein losing enteropathy play? These are more questions than answers at this time. Specific challenges are, first of all, the overall interdisciplinary care of an advanced heart failure congenital patient is being evaluated and then potentially listed as a patient who may require inpatient treatment and waiting time. This timing question discussed yesterday is challenging, and we don't have a good, clear a solution in place. Intraoperatively, I think we need to say, and I've learned to appreciate the UCLA way of organizing the care perioperatively, to have everyone involved with as much as possible anticipation of the potentially complex scenarios evolving early post-transplantation. It is not enough if at some institutions, I would say, there is a formal consultation service. One has to sit in the same room, one has to continuously discuss the patients together and round together on the patients, and that requires person trustful interaction. And I think that's beautiful at UCLA. What also is peculiar and somewhat different from the adult population or adult onset population is the psychosocial, very complex family gestalt of a caregiver scenario where mom and dad often are involved from early on and often know the situation much better than the team that just maybe starts taking care of a patient. And the important lesson, I think, to learn is to really listen to the family members and learn from them, learn from the patient if there is anything to be added. If an early onset reparative, palliative or reparative surgery has been done and the hospital records are not necessarily all gatherable. So this is an important aspect that is going much beyond what's usually encountered in the adult onset heart failure situation. And obviously there are certain risk stratifiers into low, medium, high in a very qualitative way, but clearly there are certain risk factors specifically to the transplant situation of the adult congenital population that do include standard risk factors, but also single ventricle physiology. The ethnicity plays a role, high pre-transplantation panel reactive antibodies play a role, obviously high pulmonary vascular resistance and transpulmonary gradient play a role. Retransplantation is clearly a risk factor, and as Dr. Lax just pointed out, the need for mechanical support, obviously distinguishing between the more acute cardiogenic shock versus more elective bridge to transplantation. And then classical surgical criteria that include ischemic times and cardiopulmonary bypass times. The post-transplantation care is specifically challenging in the perioperative period that just require continued attention to every organ system and the time course of development. The case that I want to just outline as an illustration is in a way typical for the challenges, although clearly at the end of a more complex spectrum. This is a 30-year-old young lady who has a single ventricle complex physiology with double outlet right ventricle, transposition, great arteries, pulmonary stenosis, multiple VSD and status post Blaylock thoracic shunt, and attempt to close the VSD, then RA-PA Fontan, and onset of atrial flutter with atrial flutter ablation, then failing Fontan with developing cirrhosis, and being placed for heart liver transplantation, having to undergo desensitization therapy with plasmapheresis, IVIG rituximab, and because of contraindications to having a Swan-Ganz catheter placed for anatomical, for infection and for clotting reasons, then in a UNOS 1AE exception category listed for heart liver transplantation, undergoing heart liver transplantation 3 months after listing, May 8 this year, and starting with an intraoperative asystole between heart and liver transplantation, followed by a brief similar episode right after arriving in the CTICU, then 11 days post-transplantation having to undergo emergency tamponade from repair from chest wall collateral bleeding, developing renal dysfunction that requires very fine-tuned titration of the triple immunosuppression, developing hypothyroidism, having a depression syndrome that keeps her from fully doing what everyone would like her to do in terms of physical activity, loss of appetite from the 2 bags of pills that she swallows every day, and then a sacral decubitus because she can't move. And then finally, after about 3 months, being discharged home, and now about 4.5 months post-transplantation of heart liver, doing fairly well. So this is the kind of scenario where the whole team is proud to have been able to assist this young lady and is working as a team with patient and parents to accomplish something completely challenging. It's beautiful, but it's also just an ongoing concern that something else might come up. Now, 3 months out, we feel overall it's the right direction. So that leads into the more kind of statistical view on this. The International Society for Lung Transplantation lists about 2% congenital indications in the overall 100,000 heart transplant registry that accrued over the last 30 years. And the overall survival here, the curve that depicts the congenital population is the one in green. In other words, this is on the x-axis years, so we go out to 20 years, and you have a clear effect in the first year post-transplantation, where the international registry has a 75 to 77% one-year survival. Only worse actually is the retransplantation survival. But interestingly, you follow the green curve over the period of 10 and 20 years, and you see that from 10 years on, the overall survival probability is not different from any of the other adult transplantation indication. As I mentioned yesterday in the discussion, therefore the early high hazard is being at least neutralized because these patients are young, otherwise in good condition if the selection criteria appropriately applied, have a good long-term outcome. So this is just actually our heart transplant patient number 2000 at UCLA. And I wanted to mention that the international experience is, if we take out of our 2,000 plus heart transplant recipients at UCLA the last 30 years since Dr. Lack started the program, we have a similar situation that if we take the first 30 days in comparison between congenital and non-congenital adult heart transplants, there's a a statistically significantly lower survival in the congenital population. If you then go to to 6 months, you already see that things are kind of evening out, and 1 year post you already see a certain trend that the difference is not significant in the small UCLA cohort, but clearly indicates a similar trend as in the international registry. And you can see this also here in terms of odds ratio for difference in outcomes. The significance early on during the first 60 days to 6 months is not visible anymore a year post. And this is just a comparison of the more recent era of the last 2.5 years since we had the reorganization of the integrative advanced heart failure program at UCLA and the era before. So there is no difference in the last 84 transplants and the other ones that were done before. And that translates, and I think we can all be proud of the fact that was second year and consecutively ranked by the Scientific Registry for Transplant Recipients, along with Cleveland Clinic and 4 others, the best performing heart transplantation program in the country. That's a measure combined of waiting list mortality, post-transplant mortality, and transplantation volume. And just want to mention a couple of challenging areas where we need to focus attention on the rejection monitoring. Often in complex congenital anatomy by endomyocardial biopsy is difficult with access. So to down titrate immunosuppression, we're kind of fortunate over the last years to have been using leukocyte gene expression profiling, first in history FDA cleared test, based on the idea that rejection is not only intracardiac or intra-organ, but also a systemic response of white blood cells that led us to develop a leukocyte classifier that ruled out heart transplant rejection without endomyocardial biopsy in stable heart transplant recipients, basically taking out of 20,000 genes in a complex development algorithm, the 11 indicator genes that can be temporarily displayed, and a clear trend with absence of rejection can be monitored now by the simple AlloMap blood test. This then we also showed that the monitoring by non-invasive monitoring in comparison to protocol biopsy is not worse in terms of detecting clinical rejection, as well as not worse regard to survival outcomes. And so the test has been implemented in the US and Europe. And the UCLA Transplant protocol, first 2 months we do protocol biopsies, and then we have the overlap phase, month 3 and 4, with AlloMap and biopsy if patients low risk and prefers less attention to the neck by endomyocardial biopsy, then we follow non-invasively. And one second challenging area is the question of how to best allocate organs in this complex situation of adult congenital patients, where the likelihood of dying may not be accessible with the heart failure risk stratifier that is used for adult onset, and therefore the organization of allocation, including UNOS and the OPOs, needs national attention or international attention. For example, someone with a complex failing fontan with refractory arrhythmias is clearly at the same risk of death as someone with refractory biventricular failure, but may not have the same criteria fulfilled. So we need to advocate for a national policy development on this level. And as Dr. Lax pointed out, since we have 1 million adult congenital patients in the country and we have 2.4K or 2,400 heart transplants, and we predict about 10 times to 20 times more chronic or lifetime mechanical support devices, we will clearly head towards a concept of lifetime mechanical support. Hopefully not all these patients requiring total artificial heart, but in order to come up with an evidence-based framework of lifetime mechanical support in a, for example, failing single ventricle physiology, we need to do multi-center studies. There aren't really many going on at this time, and I think it's another imperative from our center, for example, to organize and help organize this kind of research. This is just our adult team that is available 24/7 if any patient gets referred, and we have this collaboration in the area. This is a announcement for our second heart failure symposium, May 18 next year, where we have a focus beyond the general overview on the congenital disease. Drs. Abelhosen, Weirden, and Williamson Lux, and the team, as well as Dr. Alejos. Team is preparing this. This is just to save the date for everyone. Thank you very much for your attention.